Welcome to the Forum, live streamed worldwide from the Leadership Studio at the Harvard T.H. Chan School of Public Health. I'm Dean Michelle Williams. The Forum is a collaboration between the Harvard Chan School and independent news media. Each program features a panel of experts addressing some of today's most pressing public health issues. The Forum is one way the school advances the frontiers of public health and makes scientific insights accessible to policymakers and the public. I hope you find this program engaging and informative. Thank you for joining us.
Welcome everyone. My name is Alana Gordon. I'm a healthcare journalist and producer here in Boston at The World. I'm also today's moderator. Our panelists, starting from my immediate right, are Mark Lipsitch, professor of epidemiology and director of the Center for Communicable Disease Dynamics at the Harvard T.H. Chan School of Public Health; Winnie Chi-Man Yip, professor of global health policy and economics at the Harvard Chan School, and faculty director of the Harvard-China Health Partnership. Paul Bittinger is director of the Emergency Preparedness Research Evaluation and Practice Program at the Harvard Chan School and chief of emergency preparedness at Mass General. Joining us remotely is Hilary Marston, medical officer and policy advisor at the National Institute of Allergy and Infectious Diseases. Dr. Anthony Fauci, the director, could not make it. He's heading to the White House, so thank you for joining us. And this event is being presented jointly with The World and from PRX and WGBH. We're streaming live on websites of the Forum and The World, and we're also streaming on Facebook and YouTube. This program will conclude with a brief Q&A with questions from you. You can email us at theforum@hsph.harvard.edu. So where to begin? So much is changing each and every day. The first case of this new coronavirus was reported late last year, and it has since sprung up in more than 36 countries. More than 87,000 cases have been confirmed, and at least 2,800 people have died from the illness, also known as COVID-19. The vast majority of cases and deaths are in China, but last week the WHO reported that for the first time, more new cases were identified in places outside China than from within. Last night, New York reported its first confirmed case, and Washington State announced its second death due to the virus. This all suggests we may be at a tipping point in the spread of this new virus. And yet there's still so much we don't know, from how easily it spreads to how many people might be infected without showing any symptoms. So today, our panelists will talk with even more clarity about what we know and what we're still trying to understand when it comes to this new coronavirus. And so to begin, we're going to start with a clip that describes how it's spreading. This clip is shown courtesy of Reuters, and it's from early last week.
The World Health Organization is warning countries to do more to prepare for the coronavirus, saying the disease is literally knocking at the door. Speaking from Geneva, WHO spokesman Christian Lindmeier drew a comparison to Italy's own outbreak, the biggest in Europe, where he says the response was pretty strong.
Medical authorities have to be ready, medical staff has to be trained, and there needs to be the protective measures for the population and the medical authorities at the same time.
Italy's effectively quarantined some towns around Milan, for example, with populations in the tens of thousands. Many countries have pandemic plans ready, and some may act upon them depending on their situation. But at the moment, the WHO says it's not preparing for another big announcement, such as when it declared an international emergency on January 30th. Italy's death toll rose to at least 7 on Tuesday. New cases climbed above 280. Spain has now reported the first coronavirus case on its mainland after a woman tested positive in Barcelona. On the Canary island of Tenerife, a hotel remains on lockdown after one of its guests, an Italian doctor vacationing there, had tested positive. Iran, meanwhile, has the highest number of coronavirus deaths outside China, where the virus emerged in December. and more than 2,600 have died.
مردم بدونن انجام شده بود.
That country's own deputy health minister and a member of parliament have tested positive for the coronavirus, as the death toll there rose to 16.
So even from there, we've seen some updates as this situation rapidly evolves. But to begin, I wanted to start with Mark, with you, explaining a little bit to us about where we are at right now, what this moment represents in terms of what we know and don't know about this virus.
Thank you, Alana. So there are a few things we know and many more that we don't know. And a lot of the job of academics and other analysts is to try to extract information and inference from what we do know and try to make sense of the information, which is sometimes contradictory and very rapidly changing. So there are very few hard facts, and then there are assessments, and those assessments we try to keep as valid as possible, but it's moving fast. So the facts are some of the ones you already heard about: the numbers of cases and deaths, the extent of geographic spread. We know that this is a coronavirus, a beta coronavirus, related to the SARS and MERS viruses that have been seen before, and also related a little bit more distantly to the two beta coronaviruses that circulate every year in populations all around the world and cause more mild disease. What's of obvious concern to everyone is the level of severity and lethality of this virus, and that is one of the biggest unknowns. What we have as data are data on the ratio of deaths to known cases, but we also know that that number of known cases is certainly an underestimate, because many people have never been tested who might have the virus, and is possibly a very large underestimate. So there may be way more people infected with the virus, and indeed there may be some people dying with the virus that we don't detect. So all of those numbers are very much in flux and very speculative. That's one of the things that we're all very anxious to try to resolve, and the best way to resolve that ultimately will be serologic studies, which are studies of people looking for antibodies in people to tell whether they have been infected, because that's the only way you can know whether someone got infected that you might have missed because they weren't highly symptomatic. So that's very much in flux. Also in flux, and a related issue relevant to the United States, is really how many cases there are. And as has been really widely reported, the level of testing capacity and the amount of testing that's been done to date in the United States is exceedingly low, orders of magnitude lower than that, for example, that has been done in one province of China. That's beginning to change. It's still low, and it will take weeks before we have anything like an adequate testing capacity. But I think what's should be kept in mind as we watch the numbers change is that some of the numbers are changing because new things are happening, but a lot of the numbers are changing because we're discovering things that have already happened. And it's really important to distinguish, oh goodness, there's a new cluster, from, oh goodness, we just discovered that there's a cluster that's been there for some time. And I think that's hard for the experts, and even harder for people who don't spend their entire lives following this. So I'll stop there.
Lots more to continue with. Hillary, I wanted to ask what's happening at the federal level in terms of international collaboration, and also domestically in terms of the preparation for this new virus in the United States.
Yes, absolutely. So I think first off, I wanted to say thank you very much for including me in this forum, obviously stepping in for Dr. Fauci, but I'm delighted to be here because speaking to this group, we're reaching a group of people who is really going to be so important in this response. Public health professionals, getting out the information that's accurate, that's reliable, is just going to be essential in these coming weeks and months. So that being said, it's pretty clear that we have very high level engagement, both in the US government and internationally with the World Health Organization. DG Tedros is engaged on this on a daily, if not hourly basis. And obviously within the US government, we have engagement at the highest level. In addition to that, we have a cadre of federal employees who have worked on many outbreaks over the years, They know each other, they know how to work together, and kind of sprung to response as they have in other responses in the past to MERS, SARS, to Ebola, to Zika. Within that realm, CDC obviously is taking a very important lead on public health measures, which will be essential to this response. The NIH's portion of this is to accelerate research on countermeasures as quickly as possible. For that effort, we are able to benefit from the fact that we have long-term investments in coronavirus research. We have experts who have worked on SARS and MERS, and as soon as they saw this outbreak reaching the international community, they jumped to the task. We can talk more about that as we move forward. Thank you.
Great. So Winnie, on to you. You're part of this China Health Partnership, and here at Harvard Chan School, you've also been communicating with public health leaders in China, and we're wondering what you've been hearing and how this has evolved and what's happening right now.
I think the last 2 months, what has been evolving in China is like you're on a rapid train, and also driving that train in the absence of knowledge, because as we said, the virus is new. So I think the first month China was really doing a lot of things that in retrospect I think they wish they had done it differently, but they wish also now that body of knowledge can be given to other parts of the world that can help to not repeat those steps. But by the time that China recognized that it's an outbreak of very serious significance, which is around January 20th, China has been, I would call it, in a firefighting mode, locking down Wuhan and imposing very, very strict travel ban across the entire country, extending the Chinese New Year holiday, which means that don't return to work, don't return to school, and limiting public gathering, which is pretty much all the strategies that I would say, experts would say those would be the right strategies in the absence of not knowing what the virus is and also not having tests. But I think China is now transitioning to another phase that is from a nationwide approach to a more targeted approach, dealing with Wuhan, the hotspot, very differently from the rest of China, so that it can allow the rest of the economy and the people to gradually return to some normal life and activities. Definitely in the last month or so, there's huge economic cost and also social cost in terms of people being isolated and not being able to connect. But China is a country that you can actually make people do that and conform to that. The question is, if other parts of the world actually get to a Wuhan situation, would other parts of the world be able to impose those kind of policies? So we should avoid going to there. And I think that's how the Chinese colleagues now feel that they are also having a few months feeling that, oh, is China doing something really badly, to now feeling that they have done their best to try to overcome the difficulties and trying to draw lessons in a more scientific and nuanced way.
And so, Paul, you lead up emergency preparedness at MGH and Partners Healthcare. So what are hospitals, primary care practices in the U.S. doing right now to prepare?
So I think we are trying to learn everything we can from the data and from our Chinese colleagues to try and make sure we're as ready as we can be. I think because of the social distancing measures, other interventions, there has been some delay in how the virus has spread outside of China. And that's given us some time to try and improve our preparedness. Now, certainly, hospitals, healthcare providers across the country have been preparing for a long time. Some of you may remember back even as far as 2003 with H5N1 influenza, bird flu, that really had the United States try to fast track some of its pandemic preparedness. And we've certainly had the outbreaks of H1N1 flu in 2009 and some response for SARS and MERS. But that all being said, facing a threat like this as probably the most substantial public health threat, the most significant threat to healthcare operations that we've faced since we started worrying about pandemics since 2001, I think really is a challenge. Healthcare system was focused initially, I think, on applying the CDC algorithm of identify, isolate, and inform to make sure we picked up patients with the right symptoms, the right travel history, isolated them, did testing when appropriate with public health guidance, and really made sure that they tried to dust off their training protocols, their frontline worker safety protocols, so that we could respond to patients as they would present. But just as Winnie mentioned that China's in a period of transition, I think the US healthcare system is now in a period of transition from looking to identify single cases to pivot to identifying larger numbers of cases to trying to have to sustain the surge. And I'll come back to what Mark talked about, which is testing is really the biggest barrier we face. There are many, there are lots of barriers, and we may talk about them, but I think trying to make sure we can know who does and who doesn't potentially have the virus is going to be one of the most significant challenges in the healthcare system.
So thank you all for kind of these brief opening remarks. We're going to shift the conversation now and take a deeper look at these issues that all the panelists here have raised. So first we're going to watch another clip. It's about the race to develop a vaccine against COVID-19 and the challenges of getting such a vaccine to patients who need it. This is from Reuters from early last month.
Novavax is one of at least a dozen drug makers racing to find a vaccine for the new Wuhan coronavirus. The Gaithersburg, Maryland-based company already has a vaccine in development against MERS, another type of coronavirus. But while reports of a supposed breakthrough took financial markets out of their rut this week and sparked optimism that researchers could find an effective treatment, companies Reuters spoke to said not so fast, warning they have a long way to go to help those infected from the outbreak of the flu-like virus that has killed more than 500 people in China and shows no signs of slowing down, with thousands of new cases reported each day. But Novavax research chief Gregory Glenn thinks the biotech company is in a good position.
Novavax has in the past gone from getting the gene sequence, identifying the virus, to starting testing in 90 days for Ebola and for a pandemic potential flu vaccine. So we've done it, and so everyone's very focused on trying to compress these time frames.
Johnson & Johnson and Gilead Sciences are also rushing to develop treatments. And it's no easy feat, according to health experts, to move vaccines from the lab to widespread use in patients involves a number of hurdles. In addition to scaling up manufacturing capacity and building distribution networks, there are also regulatory hurdles that include carrying out large clinical trials, in a process that could push back a drug's release date by a year or more, according to executives from companies involved in the effort. And it's also pricey. Investment costs could run as high as $800 million for a vaccine that may or may not prove profitable. One analyst pointed out that by the time a vaccine is deemed safe, the outbreak could be abating.
So we just heard this clip about some of the challenges of quickly developing a vaccine, but countermeasures like prevention and treatment are also obviously critical to dealing with this virus. So I want to kick off this section talking about the research and the technology and where things are at. And I'm wondering if Hillary, you could start us off with that.
Sure, I'd be happy to. That was a really nice clip, gave a very good overview. There are a number of companies and academic labs that are working on vaccines and treatment for this virus. I think I should state right off the bat, as our leadership has been stating many times over, public health measures are going to be what we need to focus on in the foreseeable future. That being said, we're doing everything we can in the background to get these kind of measures moving as fast as possible. So on the vaccine front, I've seen different numbers, anywhere from 30, 40 companies and academic groups that are working on different vaccine candidates. With the US government, a couple that we have focused on both within NIAID and the Assistant Secretary for Preparedness and Response are one, Moderna, which is an mRNA vaccine candidate in cooperation with the Vaccine Research Center at NIAID. 2, Janssen, which has announced that they're working on an adenovirus vaccine, and 3, Sanofi Pasteur. So there are a number of other candidates that we are speaking to, but those are the 3 that have been publicly announced. We're focusing for a moment on the Moderna vaccine. So we had a longstanding cooperative agreement between our scientists and Moderna. They had been working on a specific design for a vaccine that took the outer protein from the virus, stabilized it in the form that's most stimulatory to the immune system. So a stabilized spike protein. And then you deliver it in mRNA, so the body cells do the work. They make the protein that gives you the immune response. The advantage of that is that we're able to, as soon as Chinese scientists put that sequence out, we knew exactly what we wanted to give to Moderna in terms of the sequence. They did their own work in optimizing it for their manufacturing. And within the course of 50 days, they were able to have phase 1 material to us. So that's just really impressive timing. You heard Novavax timelines as well, also very impressive. But again, the entire vaccine development spectrum is going to take time. We're giving this to healthy individuals, healthy volunteers to start off with in phase 1 trials. But it's obviously a different risk benefit for individuals who are not infected, right? In terms of therapeutics, we on February 25th, we announced the launch of a trial in the University of Nebraska Medical Center for the treatment of severe COVID-19 disease. That's with remdesivir. It's an adaptive trial, so over time, depending on the data, different candidates could be looked at. But we're hoping to expand to many sites across the country and get robust data as quickly as possible. This is something that NIAID has done in outbreaks in the past in partnership with the World Health Organization and a number of research organizations. Sort of proved that it's possible to ethically and in a scientifically robust way conduct trials that give us reliable data in the disease setting.
Just to clarify, realistically, people hear vaccine, that's wonderful, but in terms of like timelines for treatments and things, what's like shortest, longest, like can you give a realistic sense of that?
Sure, so we have been saying if everything moves as quickly as possible, the soonest that it could possibly be would be in about 1.5 to 2 years. That still might be very optimistic. That's doing absolutely everything at the same time, right? Putting it into mice, planning a phase 1 trial, everything gets compressed using as fast a platform as possible. So we can hope for the best, but I think that public health measures are still going to be where we are.
So thinking of public health measures, Paul, you had talked about testing and this kind of moment and eagerness that for you, preparedness, the key is like identifying people right now and getting the testing done. How do you do that? And what's your take on the situation right now and the delays?
Well, this is certainly where the partnership between healthcare and public health is so important. And we really look to public health right now to give us the guidance for whom to test because testing is limited. And so we have all the way along been following the CDC criteria for what we call a person under investigation, a PUI. And really, unfortunately, can only test people who meet this PUI definition.
And
so
what is that?
right now, it is changing, but it involves a combination of symptoms, fever, and respiratory illness, and either exposure criteria, so initially was just China, now has been broadened to the countries with sustained transmission. But there's a third category of the first two are combining fevers and travel history, but the third is severe illness, because as we've seen reported, there now have been cases that do not have an identified travel history to one of the countries with sustained outbreak. This is frustrating for providers, it's frustrating for the public. I absolutely understand that people are worried about COVID. There's a lot of anxiety out there, and fever and respiratory illness, people say, gosh, shouldn't I be tested? And we have right now so few tests available that we have to prioritize testing for severe illness. And so that's what we work on with our state public health authorities following the federal guidance. Absolutely, again, from a hospital's perspective, as soon as possible, we would like to know in everyone where it's plausible whether or not COVID is a possibility, so that we can choose the personal protective equipment we wear for our nurses and physicians and other caregivers, as well as what care spaces we use, negative pressure, airborne infection isolation rooms. So that testing data, again, is essential to everything we do. Right now, we have to prioritize focus on the sickest folks, and to build on what Hillary said, my hospital in specific is part of a network of 10 centers like Nebraska that share a common IRB protocol for these research initiatives, and we want to be able to help identify patients in whom these therapies might be indicated and help collect data. So it all ties to that testing.
When you put your hat on of overseeing kind of this preparedness program here at the Chan School, I also think about, we have places and communities that aren't necessarily even as well equipped as Mass General. And so how do you plan preparedness outside of your doors?
So I think it's tiers, no question. Part of the reason to have a network of these 10 centers that are funded by the Assistant Secretary for Preparedness and Response is to have centers that can help others along the way. And so many of us have produced tools for triage, for training, for operation of what we call special pathogens units within hospitals where you'd hospitalize people. And we've pushed out those resources immediately upon seeing the outbreak developing across China. So we definitely do that. We also try and work with our state and our federal public health colleagues to try and maximize how well healthcare and public health can work together. We need to share with them what our challenges, what our stressors are, what are the key variables that help determine our effectiveness in response. And they need to tell us honestly where we stand. And so, the messaging, as Hillary just said, about when a vaccine is coming is extraordinarily helpful. We don't want people thinking that there might be something in the next 2 or 6 months that really isn't honestly possible. And so we have to prioritize our actions, and it's these partnerships that are so important.
So, keeping with our theme of technology and data, Mark, I want to ask you about what are you zeroing in on right now, and trying to understand, or what more types of information do you need to understand, like transmission, even that sort of thing?
In my view, there are many, many things we'd like to know, but there are two in particular that I think are really essential. One is to understand what role, if any, what role, probably there is some, children play in transmitting this epidemic. So what we do know is that children are underrepresented. There are very few cases detected in children, even in places outside of China, but especially in China. And that suggests that either children are somehow protected from infection, which is possible, but we don't really understand why it would be true for a respiratory illness, or that children are just very mildly symptomatic or even asymptomatic when they have the infection. And those are two very different possibilities, because one of the major control measures, which was undertaken, for example, to some extent in 2009 for the flu, and which would be appropriate in any flu epidemic, is to close schools. And Japan has closed schools, other countries have closed schools. We don't know if that's an important control measure or if it's just a very expensive, costly, and otherwise disruptive control measure. So understanding what role children play, which we can learn, I think, best from household studies and outbreak studies, is number one. Number two is understanding the size of what we sometimes call the iceberg, that there are, we see preferentially those people who are most severe, in part because, as Paul said, those are the people who are most likely to get tested. And then there's this pyramid or iceberg underneath those people who are mildly ill or even asymptomatically infected. And we'd like to know how many of the people are at each level of severity. And we sort of have the upper part of that profiled. And most of the people who have been confirmed as cases, most are mild or moderate, and a few are severe, and a few are lethal. But what we don't know is how many are underneath that iceberg, underneath the surface. And that's important because when we model transmission and when we project how many people are going to get infected, the models don't know how many people are sick or how many people are really sick. They know how many people are infected, because what ultimately brings an epidemic under control is most people or enough people in the population becoming immune. And so once that happens, and that can happen from a mild infection or a severe infection, then the epidemic can start to turn over. It's the same phenomenon of herd immunity that we talk about when we talk about vaccination. If there are enough people immune in the population, that protects the other people. So understanding where we are in that curve, whether when we see 100 cases, whether that represents 100 or 1,000 or more, that's really important.
An unfair question from that, but when will you know?
I learned on a phone call with the World Health Organization this morning that there are serological studies underway in China. Those are studies to find out, as I mentioned earlier, whether people have been infected, and that's a really important way. That's the sort of ultimate denominator, and that also is a direct measure of immunity, or relatively direct measure of immunity. So those studies are underway. I don't know how long they will take. There are other ways of doing it, especially in big outbreak settings, like the Korean church outbreak. There's some data coming out from that, which are hard to interpret at the moment, but are coming out.
Mm-hmm.
So I think we should look to other settings like that and plan to rapidly respond to settings like that with our own studies, if and when they happen.
So I want to shift a little bit to the theme about information sharing and data. So Winnie, I wanted to ask you about how, in your experience, you see the management and spread of good information and also misinformation.
So I can like to speak more about China's experience. I think social media has played a huge role in this outbreak, but both in a positive and a negative way. There's no question that social media penetration in China is very wide, all the way to rural areas. Everybody has a cell phone. So it could have been a very, very effective and useful media for public education, but I think that what we have seen is also there has been lots of rumors, lots of unverified facts, and conspiracy theories that have been spread across the internet that has actually caused a lot of panic and fear, and sometimes unnecessarily. But I have to say that the widespread use of social media in China has also provided some checks and balance for the government as well. So there are pros and cons to it. My question is there a middle ground? How do you use it in a healthy and constructive way to educate people? Because the kind of fear and panic that you see in America now, in China, I think I can say is 10 times during that time. And you can see that social effect immediately overnight. People just buy up all the medicine, buy up all the masks, which is actually not needed, and also food. I would say that there are multiple roles it can play, but it hasn't been used in its best way. But relating to social media is also, I think China has been quite effectively using the internet platform for online consultation, which actually has helped significantly to relieve the burden of the healthcare system that has been shifted to focus on treating COVID. And so the volume on online consultation surged by about 10 times. Some of them is just to get information, and I think it is necessary. But we also have some of our collaborators showing data that about 30% of those consultations would include questions of stress, of distress, especially those coming from Wuhan. And I think that provides yet another very important database to understand the impact of these kind of massive social distancing.
And so, Hillary, I wanted to ask you about how information sharing has, some of the successes and some of the weaknesses on a global scale have worked. And also maybe playing off of that, what are some of the lessons to take in terms of informing the public here about information and misinformation?
Sure. So I'll speak about it from the scientific community's point of view there. I think that this outbreak has really shown us the power of rapid information and data sharing. With the Chinese example of sharing the sequence on January 10th, just a few short days after the outbreak was first recognized. In addition, groups around the world have been sharing their sequences as quickly as they get them. Which has been really helpful to understand the spread of the virus and any changes over time. In addition, groups have been sharing their publications as quickly as they can on preprint servers. The journals are moving as quickly as they can to get them out and peer reviewed, and I'm sure a number of us have participated in those reviews. They're quite fast, but everyone is really taking an all hands on deck approach. The preprint servers are a very powerful tool. Individuals can get their information out quite quickly. I think at times people forget the buyer beware aspect of that, right? Which is that those have not been peer reviewed. They've not necessarily been as pressure tested as you might want them to be. And there are some well-recognized examples where that's caused problems. Including regarding the sequence of the virus and origins. So I think there are, again, positives and negatives, even within the scientific community. I think social media for the scientific and medical community has been quite powerful. Once you figure out who those trusted voices are, consulting them, getting information flowing back and forth, and seeing their dialogue in real time has been very helpful, I think, to investigators across the country. In terms of messaging from the US government, from trusted sources, state and local public health departments, it obviously gives us a really nice way to get information out as quickly as possible, not wait until we can do formal press release, et cetera. So it's a good tool, and we just need to be careful with the sources that we're trusting for that information.
I want to ask Paul about kind of moving into hospital preparedness. You talked a little bit about preparing for surges, or how to prepare healthcare staff, as well as like isolation, quarantine. So what are how are hospitals readying, but also like really where are you at with that? Yeah.
So again, the good news is that we are certainly building on previous effort, that this isn't something that just started in January this year. However, it's also important to acknowledge that the healthcare system operates pretty close to full or beyond full every single day. That most inpatient beds are full. Most emergency departments are beyond full. If anyone who's been to an emergency department recently could tell you. And so it's pretty hard to have your car going close to the red line on the highway and then have to go faster. So we are stuck, I think, in a tough position. So we look at what other alternatives we have. Many healthcare systems have actually been looking at home visits and telemedicine, being able to see your doctor without having to come into the hospital. I think the trusted source of information comments are extremely important. People don't necessarily know yet that more than 80% of cases are mild illness, and people don't need to seek medical care. And I think one of the lessons, we've learned so many lessons from China, one of the lessons we're going to have to try and adopt in this country is to try and help people know when they should and shouldn't seek care. It's a new disease, people are fearful and people want a diagnosis, yet bringing everyone into emergency departments or urgent care centers, even their doctor's office, stresses the healthcare system and frankly makes disease transmission worse. So we have to find ways of sharing this information in a trusted way that the public believes, or delivering telemedicine, or both, and we're working on that right now. In terms of the inpatient side, as Mark had mentioned, some number of patients do unfortunately have critical illness and some number of patients die. And so we have been working at trying to protect our healthcare workers so that when they deliver care, they have access to the right personal protective equipment, right protocols, and we have ways to expand our care spaces. So as one example, my hospital has a select number of rooms with what we call airborne infection isolation, negative pressure, to care for the first round of patients, but recognizing that may be inadequate, we have other contingency plans to make an entire floor of 36 beds, what we call negative pressure, by really ramping up the fire exhaust, doing some other things. So we have contingency plans to really do extraordinary actions. Now, there are patients in those 36 beds right now, and what that means to free them up is that we have to potentially change the way we deliver care. This means potentially delaying admissions, delaying surgeries, other procedures within the healthcare system if we have to make room for patients who are acutely ill. And we've been thinking about this. I keep coming back to the public health and healthcare partnership. We have to make sure we're doing this fairly and uniformly across the healthcare system so that all patients have access to care. And we're using roughly the same criteria so that we can make sure we adjust our healthcare operations safely and continue to provide care to those who need it. But depending on how significant the outbreak is, we may have to make some challenging choices.
Sounds like realistically there are trade-offs and there are things to really consider.
There are absolutely trade-offs. The most important thing is to have frameworks with which to evaluate these trade-offs, both at individual healthcare organizations and across cities and states and across the country.
I wonder, Winnie, as you're hearing this, how you compare that, you referenced before to some of these like telemedicine visits, but to China's experience, I'm thinking about these hospitals that were built very quickly.
Yes. Yes, what Paul described is actually very consistent with what happened in China, but probably at a much more intense scale. As you were referencing to, China built 2 hospitals with 2,500 beds in just about a week's time. And then it's then converted several stadiums with about 11,000 beds for the 80% of the population who only have mild situations. I'm not sure many other countries can replicate that at that scale. And there are costs in the sense that 40,000 health workers, physicians have actually go from different provinces to just help Wuhan to deal with this situation. So most hospitals in the rest of China basically has shut down their outpatient visit clinics, except for emergency. Most of the elective services have all been postponed. And so, in fact, we're seeing that people with chronic disease management need all have been delayed in terms of the care that they are getting. So yes, as a crisis response, it may work, but if the system had been working better, as I have always said, maybe it is better to prevent to have to do that rather than to be able to build a hospital very quickly. And China has to build these hospitals partly is also it has a very weak primary healthcare system in terms of both competency and trust. The huge surge in the number of patients going to hospitals, a large number of them are probably having just cold flu symptoms, but no, they only want to go to the hospital, probably getting themselves infected, and also just crashing the system.
Yeah. So we've been getting a lot of questions from our in-studio audience and online, so I want to actually shift now to taking some of your questions, which have been submitted as well. So I want to start now with Jeff from the New England Journal of Medicine, who asks, and Mark, perhaps this can be for you, given the data that's been accrued so far, how certain can we be that a 14-day quarantine is adequate?
I think it's a numbers game. So I think what the question is referring to is that there have been some reports of very long delays between an exposure of a person and the onset of their symptoms. And the more data we get, the more the longest number in that list is going to be a big number. So as the unlikely events still occur, and if we get thousands more cases, we're going to see more examples of that. The question is not really whether it ever happens that there's a long incubation period, but whether it's frequent enough to matter. And frankly, I think we're in a phase where quarantine and isolation of individual patients is going to be still an important piece of the response, but is not going to be the main focus of the response as the number of cases grows. So in the countries in Europe and elsewhere, and in South Korea and in Japan, I think they're already seeing a transition from the so-called case-based response to the more social distancing type of response. And so I think getting the exact number right for quarantine matters for those very rare patients, but you need a rule of thumb, and I think 14 days is consistent with the main bulk of the infections.
That's really interesting to think about, looking beyond that time of just broader measures.
Yeah.
So this question comes from Nell Greenfield-Boyce at NPR. Hillary, this might be for you. What role will the Strategic National Stockpile play in the U.S. in response, and what stockpile that could be of use?
So that's a great question. So the Strategic National Stockpile obviously has some important assets that could be leveraged for this. There's been a lot of attention paid to personal protective equipment and the proper use of that, really making sure that it's available for healthcare workers and to cover patients who are actually symptomatic, and also in order to prevent spread within our healthcare setting. So that's one important piece. In addition, one part that we're going to need to study more is the incidence of bacterial infections in our hospitalized patients. That is another asset that could be important. It certainly is for influenza, but it's something that we're continuing to learn about for this virus.
Maybe this also translates, I don't know, Paul, if you want to weigh in a little bit, and we also have a question that leads in from Michael, which is about, if you're talking about being at 90% capacity right now, how do you further accommodate, and what materials do you need?
Sure. So I think that the supply chain is absolutely overall one of our biggest challenges in the healthcare system. Personal protective equipment, as Hillary mentioned, specifically respiratory protection, specifically N95 respirators are one of our concerns. We still don't know for sure, although some of my fellow panelists may correct me, the degree to which airborne transmission may or may not play a role in the transmission of this disease. And we use N95 respirators for airborne transmissible diseases, but we use simple face masks for droplet transmitted diseases such as influenza. And it's going to be a very important piece of data for us to learn as to whether or not we need N95 respirators. Currently, my own hospital system has received one shipment in the past 4 weeks, and we normally get them weekly. And so we have a challenge with arranging for sufficient amounts of PPE, but we have stockpiles in our own system. We are managing our inventory very closely, and we are adopting conservation efforts to make sure that we provide a safe environment for our workforce to deliver care. If we exceed all of that, then we will potentially reach out to our state and federal colleagues to try and request assets from the Strategic National Stockpile. But honestly, all of these stockpiles are limited when we're looking at a 2 to 3 maybe month wave of illness. So there are other aspects of the supply chain I would mention just briefly besides PPE. A large quantity of both medical supplies and pharmaceuticals are manufactured in China. And so some of what we're looking at is demand, some of it is manufacturing. As Winnie pointed out, the outbreak in China has had a dramatic effect on manufacturing capability on output. And so we've already heard some other products, such as surgical gowns, may be delayed in a couple months. So there's a 2 to 3 month window where we might see some ripple effects in our supply chain from what's manufactured in China. And we're doing our very best to identify what those products are, to identify alternatives, but I think it may not just be PPE that we see, it may be a number of other items in the coming months.
So this question comes from a first responder, Tom Guerra, chief of Canton, Ohio's fire department. And this is a really interesting scenario. He says, as a fire department, we run first response paramedic units in Canton, and since COVID-19 is not verified in a patient unit until there's testing results, and you talked about those delays, until that's confirmed, what should these first responders be doing in terms of personal protective measures, because these first responders can be vulnerable, and we're talking about in these situations undiagnosed patients.
So I think there's some things that we're trying to tell everyone in the public. Wash your hands, cover your cough, avoid touching your face. And sometimes that seems almost so obvious as to not be important. But there are real studies that show decreased transmission of disease with those basic measures. And I actually came from an EMS background myself. That's how I started my whole career in medicine. And so I understand when you're out on an ambulance how hard it is to talk about hand hygiene or protection, but it's extremely important. In terms of personal protective equipment protocols, when to wear a respirator or a gown or gloves, this is, and I'm sorry I come back to the same topic, but where partnerships matter. EMS services have medical directors, generally speaking. Those medical directors, those chiefs, such as your writer, really need to be partnering with public health for the protocols for when to don and when not. If we do it too much, if we wear it for every case, we will run out, to be blunt. If we don't do it enough, we put our first responders at risk. And so we are doing this in the hospital just as we are doing it with our EMS system here in Boston, coming up with the right protocols that identify the high-risk situations, make sure we have a trained workforce that know when to put on the PPE, and then when they do care for patients that ultimately are diagnosed to be infected, we make sure we close the loop with those services so that they know the risk that they may have been exposed to.
So a lot of questions have come in about travel, and this one is from Kaiko, but having to do with both domestically but also abroad. And Mark, maybe you can weigh in on this, and Hillary as well, but the question is, like, do we have to limit travel overseas given that the virus is spreading? So there's this question of weighing, like, yeah, what kind of considerations should be taken right now? And then also, is it reasonable to cancel big meetings and events? And there's just some more detailed questions here. People are wondering about the trade-offs too, with like the economic trade-offs. So that was a lot, but.
Sure. So I think it's a very subtle question, and a month ago it was easier to answer, and a month from now I think it will be easier to answer. Right now it's actually possibly the hardest time to answer. And the reason is that a month ago it was clear where the risks were. They were in Hubei province and other parts of China to a degree. A month from now, and so travel to there was clearly not recommended. And a month from now it may be so many places that where you are is not a major determinant of your risk. Right now we're kind of in between, and furthermore, we don't know what category each place falls into. So the United States hasn't tested enough to know whether we're high, medium, or low risk place. We're probably not high, but we could be medium. Indonesia hasn't tested enough to know whether they're high, medium, or low risk place. The places where we know there are cases are high risk, but the places where we don't know, we don't know. So I think it's really hard, but I think the way I try to resolve it at this stage is to think about what is the totality of risks from travel. And it's not just being in the place, it's also the level of congregation of people from other places. You usually travel for a reason. If it's a business trip, you may be traveling to be in a room with a lot of people from areas of higher risk. The conveyance that you're on may be also a group of people with different exposures. So I think limiting optional travel makes a lot of sense, not so much because you know that it's high risk, but because it's part of a response to try to slow this down. I don't have a good answer for what to do about, and in fact we have a decision in our own family for our child traveling to some place that currently has no cases, but we don't want her to be quarantined when she comes back if they discover cases in the meanwhile. And those are all calculations that people have to make. It's hard to give a very general answer now.
Hillary, would you like to weigh in on that?
I think that was an excellent answer. There is data that's going to come out over the coming weeks. The situation is going to change. Obviously, from an international perspective, the State Department is looking, and CDC are both looking at their travel warnings on a daily basis, if not more frequently. And they're updating as quickly as possible. That being said, often you're trying to make travel choices 2 weeks ahead. I have talked to many members of my family and friends about this, and told them that I will keep an eye on the epidemiology and let them know my current take on it. But I think in general, keep making sure that you're consulting those websites and thinking about your personal risk. For example, the risk of somebody traveling who is a young, healthy person, like I can't see the audience, but I imagine there's a lot of them in that audience, is very different from, somebody who is in their 70s, has hypertension, et cetera. That person might want to strongly reconsider travel. But I think at this point, personal decisions informed by what the local epidemiology is.
Yeah. So this next question kind of leads into, Mark, what you were talking about in terms of places maybe not testing to have awareness of what's there. But to what degree, like why, this comes from Ahun, why have there been few cases in Africa? And also, how does like time of year and weather play into this?
Yeah, thanks. Those are both really good questions. I think the few cases in Africa are a combination of certain parts of Africa not being heavily connected to China and other parts of Africa being heavily connected to China and not having enough testing. So I think it's a testing artifact in some places, and it may be a true thing in other places. We've been very interested. I've been working on seasonality of influenza for a decade now, and we've been really interested in trying to understand the seasonality of this virus. Other coronaviruses are clearly seasonal. If I had to predict, I would say this virus will become somewhat modestly less transmissible in the summer. But our current estimate is, and we're very actively working on this right now with collaborators, is that the reduction in transmission will be visible, but not enough to actually bring it below the critical threshold. So it will slow the growth rather than turning it downward. But that's an inference because we're dealing with a virus that nobody's looked at. It certainly can transmit in hot, wet places.
Interesting. So this question comes from Anissa, and I feel like I could ask this to the whole panel, but like, what's the best way to quell public fears and also combat racist comments and attacks that have been made? I mean, we could just...
We can all maybe take a bit of it. I think so much has been made of education and knowledge, and I think we need it on the public health side, we need it on the medical side, we need it for the public. The way the public will feel better is by knowing how much illness can be mild and what their personal risks are, as well as how to protect themselves. Those are obviously the factors that help to make people feel somewhat more reassured. And I think with respect to comments and others, I actually would say the same thing about my comment with seeking medical care, is we are all in this together. This is a global disease, this is a global outbreak. This affects all of us, and we are all one population, both in terms of our health and social distancing. We should be grateful for actions of the Chinese, the Italians, others who have delayed some of the spread to help us respond. And we should all recognize that we have a stake in responding effectively together, and that's true in our neighborhoods as well as in the country and our global perspective.
I think it will be important for people to keep remembering that this is a new coronavirus. By being new, it means that we are living in a world of uncertainty. And so we all have certain responsibility of making probabilistic assessment rather than thinking that someone will give them a deterministic reply. And I think that reality should just be given to the people, but also feel that managing public expectation and knowledge is very important to be done in a situation where the public and the government and the system is in a trusting relationship. And so being able to be transparent, being able to provide information in a way that we are working together, I think is very important.
Yeah. So, I just want to in terms of adding that, we have just a couple minutes left, so I'm wondering if you could also pack that into kind of final notes and wrap up, and we'll kind of go through.
is what I wanted to say for my final event. Anything. Anyway, so I think my take on quelling fear is really about what I wanted to leave people with. I think that the fear is a natural response that can lead us to do good things if it's channeled into self-protection rather than into harming others. And self-protective activities include all the hygiene measures that were mentioned earlier, includes getting up to date on vaccinations to prevent needs for contact with the healthcare system. It includes, if you smoke, quitting smoking because you need your lung function, and that is important for this. It includes staying home from work to protect others if you're sick. It includes making that possible if you're a business owner. These are all individually self-improving acts that will reduce one's own risk. And this is a happy case where every one of those things also has benefits to the community. Slowing the epidemic is what we have to do if we can't stop it. And all of those measures, small though some of them may be, help to slow the epidemic. So there's a real coincidence, a real coalescence between individually self-protective measures and measures that will benefit the community. As long as they're those kinds of measures and not avoiding people you think are somehow more contagious or because of their race. I mean, that is not helpful to anyone, of course, but the basic hygiene and self-protection measures are in fact socially beneficial.
Hillary, I'd love to turn to you just for a couple quick wrap-up comments for the panel.
Sure. So it's hard to come right after all of those excellent comments. I agree with everything that has been said there. I would also come back to something that I said at the beginning, which is that when we talk about trusted sources and getting the word out there, you guys are at HSPH, right? You have access to all of the best information, and you can be some of the best communicators that we have out there. So I would really take it upon yourselves personally to help in this effort. I'm sure many of you already are, but I'm sure it would be much appreciated by everyone up on that panel. So thank you.
Well, that wraps up. We are out of time. So thank you to everybody, to our panelists, for participating in this. Please, let's keep continuing this conversation. It's very important. And also please note that separate from this, the next panel happening right here is on March 18th at 1 p.m. It's on homelessness in America, health, housing, and the search for solutions.